Good evening, everyone. Um, so today's topic is we've started this series on sports cardiology, and the first topic is about exercise and heart. So we know that sports cardiology is coming up in a big way, and all of us need to know something about it. So hence the need for us to start this series. So, introduction wise, we know that competitive athletes and highly active individuals, whom we call as CAHAP, that is competitive athletes and highly active people, are a growing population globally. We know that in India, very few were running marathons earlier, but we can see now the crowd in the marathons are so huge. So, like the TCT this time in Bangalore, Tata Marathon had around 15,000 people running. So that way, we need to know to risk stratify these patients and also to know what exactly we need to look into when we are looking at a patient who is an athlete. So, lifelong commitment to physical activity improves health and longevity. This all of us know. But in some, it may also increase risk, which we also get to know many a times when we see people running marathons. And we should know very clearly that any form of exercise is not going to confer immunity against disease. But in a patient who, in a person who is totally healthy, definitely exercise improves longevity as well as health and fitness. So the aim of sports cardiology mainly is to do screening for prevention of adverse events, risk stratification, differentiation from athlete's heart, and also to give replay prescription. So once they have had an event, when can they start playing again? So these are the aspects that we cover in case of sports cardiology. So this is just an illustration which I've taken from Journal of American College of Cardiology. And here very clearly we know what is comprehensive sports cardiology. So one is we have differentiation of exercise induced cardiac remodeling, that is EICR, from
ಇದನ್ನೆಲ್ಲ ಅಲ್ಲೇ ನಿಮ್ಗೆ
cardiovascular
ಬರ್ಕೊಡಿ ಅಂತ ಹೇಳಿದಾರಾ
pathology.
ಇವತ್ತು ನೈಟ್ಗೆ ಒಂದೇ
You
ಸೈಡ್
have
ಅಲ್ಲಿ
to
ರಿಲೀಸ್
will have
ಅಂದ್ರೆ
to
ಈ ಕಡೆ
mute the person, I think. Yeah, thank you. So then evaluation of symptomatic competitive athletes and highly active people. Once they have symptoms, we need to find out what is the reason for the symptoms. Next is management of these competitive athletes and highly active people with cardiovascular disease. And lastly, what we do as collaborative pre-participation cardiovascular screening to find out who is susceptible for a cardiac event during a exercise and prevent it from happening. So, what do we mean by remodeling? We know that a lot of changes happen in the heart because heart works 24/7, we know that. And when there is exercise load added to the heart has to work extra in order to meet the demands of the body by increasing cardiac output, increasing heart rate. So, when all that happens, there are some remodeling that happens in the heart. So, what are the activities which increase the remodeling? We know that exercise consists of two types. One is a static strengthening exercises, and the other is a dynamic component of exercise. So, when someone is used to a moderate to high intensity dynamic exercise, the remodeling is maximum. And when you add endurance to it, what do we mean by endurance? The duration. So let's say somebody is running a marathon, they run for 4 hours. So when the duration of the activity increases, dynamic activity increases, the time of exposure, that will tell us how much more the remodeling is going to be. Let's say it is somebody who's into soccer, so they will probably will train for a short while every day, maybe half an hour, 1 hour. But when it comes to an endurance athlete, they may train for 2 hours, 3 hours every day. There are people who run 100 kilometers, 100 miles. So we know that, those people are going to be training much more than the regular soccer player. That way, the time of exposure is going to be longer and hence their remodeling is going to be much more. The next thing is a VO2 max. When we say VO2 max, it is a maximum oxygen consumption at high level of activity that happens. It gives us um, a, idea about the um, what do we say, an aerobic threshold or the aerobic um, aerobic metabolism in a person. So VO2 max is what is going to give us a clear idea, and it correlates clearly with that of the LV remodeling or LV or the RV remodeling, heart remodeling that happens. Grossly, we say that VO2 max is around 3.5 into the METs. So let's say somebody is doing a treadmill, we may put them to test of 10 METs or 13 METs or 18 METs. So 3.5 times of that METs will be the general VO2 max of a person. But if we want to definitely measure the VO2 max, we need the cardiopulmonary exercise testing, and that will give us the most accurate VO2 max of the person. Then we look at the cardiac size, and the VO2 max generally correlate very well. So when there is dynamic exercise, one is the volume increases and also the wall stress increases. Basically, because some amount of afterload increase is there, both for the LV as well as for the RV. So this way, all the chambers can actually undergo some form of dilatation, which is part of the remodeling due to the exercise. So when we look at this graph, I know it's not very clear, but all that I want you to concentrate on is as the exercise intensity increases, the lower two graphs are showing about the LV and the RV volume. So at rest, the volume is at one level. As the moderate intensity exercise increases, at moderate level, the volume increases maximum. So once the LV or the RV volume reaches the maximum limit, after that it will undergo some form of a fatigue, like a Starling's law. Beyond that, it can't keep increasing in volume. Then the volume stays stationary, or then it starts coming down. And always we know that when compared to a non-athlete who has a lower volume, an athlete will have a larger volume. And similarly, when we look at the stress also, an endurance athlete's stress remains almost static when compared to a non-athlete. So wall stress also increases both in the RV as well as in the LV. So this is just a graph to show us a person who is how much in 24 hours, how much of sleep, how much of inactive time. That is, inactive time means the regular time at work that we spend where we are not exercising. So the first 24-hour schedule that it shows is somebody who is not an athlete, who's not exercising much, giving just limited time to the exercise. As the exercise time increases, you can see this is a team athlete. Team athlete may give around an hour or less than an hour for everyday activity, because let's say this is like the soccer player who's just going to spend a certain amount of time and that's it. But an endurance athlete, you can see in the third graph, who's actually spending quite a bit of the 24 hours, maybe 3 or 4 hours in activity. So normally what is recommended for us is, we know it is 150 minutes of activity per week is what is recommended. So at least 30 minutes of activity, 5 days a week is enough, is what is recommended by most of the associations. So that accounts for only 2% of the entire time. But endurance athlete or a team athlete may actually go much beyond this, like even up to 10 or 20% of the time being spent with exercise. So that way we need to keep a watch on that. So here we see an athlete who's running. We see that his VO2 max is increased. And similarly, in order to maintain that VO2 max, his stroke volume and heart rate will increase. His end diastolic volume will increase. And because there is some amount of increase in the afterload, his LV wall also will get thickened. So heart rate variability will increase over a period of time. He becomes vagotonic and his resting heart rate will come down. So what are the other changes? You can see here the size of the heart pre-training. You can see the LV and the RV. So when we look at endurance training, like how I have already explained, so endurance training is going to cause both LV and the RV to dilate slightly. Both of them are going, because volume increases. Next is both of them are going to thicken. The walls are going to thicken, So there will be some amount of left ventricular hypertrophy and right ventricular hypertrophy, which in turn will also increase in the size of the left atrium and the right atrium. They can have normal to slightly reduced ejection fraction, and they will have normal or increased diastolic function. So their early diastolic filling will be much higher, and the LV twisting and turning will also be more enhanced in order to become more efficient to get the cardiac output up. When we look at strength training, that is, most of the gym goers. So here it is mainly some amount of left ventricular concentric left ventricular hypertrophy. RV is most of the times unaffected, and they will have hyperdynamic LV ejection fraction, and they may have a little reduced diastolic function. So these are the few subtle differences between a person who's strength training and endurance training, and most of the times it may be a mixture of both. So whenever we interpret exercise and heart related changes, we need to see what type of exercise, what duration of exercise, and what intensity of exercise the person is doing. So here we see a person who is an endurance athlete. So you see the first picture of the cardiac MR, where we see the RV and the LV are normal size. Then the person is going through an endurance training. With the endurance training, there is going to be greater cardiac volumes. So, and the lower relative wall thickness. So there are certain aspects which actually also contribute to this. One is sex. Men are more prone for remodeling in the heart when compared to that of women for the same level of activity. Ethnicity, like blacks have much more remodeling when compared to the other ethnicity. Then polygenic traits. Let's say someone has ACE gene defect or nitric oxide synthase defect. So these type of defects will um, uh, predispose the person to develop remodeling much faster than other athletes at the same level or intensity of activity. So after prolonged endurance, you can see the same cardiac MRI of the same person where LV, RV, and LAR, RA are dilated. So, but what are the positive effects of all this? Positive effect is greater longevity. They have less heart failure and fewer coronary events. What is negative is if there is so much enlargement, some amount of atrial fibrosis can happen, which can lead to atrial fibrillation in the future and sinus node dysfunction in the future, which may happen in view of age also, but there is some predisposition due to the endurance athletes. So this is a slide that we need to spend a little time on. To the left hand side, we are seeing the intensity of static component of any exercise, and along the x-axis, we are able to see the dynamic component of the exercise. So if we are looking at both static and dynamic component being the lowest, we are looking at yoga, bowling, cricket. So all these are exercises where we are looking at the lowest part of both static and dynamic. So we are not expecting too much changes in the heart. So as we go further away, as the dynamic portion increases, these are the people whom we are going to expect some amount of changes in the heart. So both dynamic and static being highest is in triathlon athletes. Now with Mr. Tejasvi Surya doing triathlon, all of us are geared up about triathlon athletes. So they are going to have a lot of changes in the heart muscle as part of remodeling. So kayaking, cross country skiing, and cycling, these are the sports which are going to have maximum amount of cardiac remodeling. So down, we can see in the picture what are the changes that happen in the LV and the RV. So increasing static component is only going to cause concentric LVH. Increasing dynamic component is going to cause LV and RV dilatation. But both static and dynamic component increasing will cause both LVH as well as chamber dilatations. That is the maximum remodeling that we see. This picture again I've got it from the Journal of American College of Cardiology. So when we look at intensity of training and the amount of training, so as the amount of training and the intensity of training increase, they are the ones with the greatest fitness and also the greatest cardiac remodeling. And as the intensity comes down or the amount of training comes down, they will be the least fit and the least cardiac remodeling people. So, what causes these remodeling is what we need to know. One is there will be hemodynamic load and mechanical stress, increased sympathetic activity, which leads to increased exposure to catecholamines, and also there is increased release of some hormones like the growth hormone, thyroid hormone, some of the growth stimulating factors, IGF-1, VEGF. So all these will cause multiple signaling pathways which lead to cardiac myocyte hypertrophy, and increase in the extracellular matrix also in the myocardium, which can to some extent lead to fibrosis, but that aspect is not very clear. Cell survival increases, some mitochondrial adaptations happen, and angiogenesis also happen. All this will increase the heart size and also improve the cardiac function. So this I know is a busy slide. Basically the same thing that I showed in the previous slide, showing it at the molecular level. So we know that the apoptosis comes down and cell survival increases. Cell more cells are converted to myocytes from the progenitor cells. So all this happens as part of those cytokines which I have told. But there can be some cytokines which also cause a maladaptive process. Those maladaptive processes like an increased myocardial, let's say, concentric hypertrophy, which is disproportionate to the level of their VO2 levels. This can happen when there is more of TNF alpha, tumor necrosis factor alpha stimulation. All this happens when the ACE inhibitor gene, enzyme gene is affected, or when nitric oxide synthase gene is affected. So they already have some gene effects which predispose them to develop increased exposure to tumor necrosis factor alpha and maladaptive processes. So this is, we have spoken about the molecular aspect. We have spoken about how we quantify somebody's intensity of activity and accordingly look at changes. Next is we are going to do the electrocardiogram for any patient. So ECG is the next step to see whether it is part of athlete's heart or something abnormal. So according to the 2022 latest guidelines, these are aspects which are part of the normal ECG in a case of an athlete. So they can have increased QRS voltage, either an LVH or an RVH. They can have incomplete right bundle branch block, early repolarization changes, ST elevation followed by T inversion V1 to V4, which is seen in black athletes because of the exaggerated juvenile pattern which is seen in them. Then T inversion V1 to V3 is the persistence of the juvenile pattern. So because of the vagotonic effect, they can have sinus bradycardia, first degree AV block, and second degree AV block, Wenckebach type, that is a type 1 type. So these are all normal in a case of an athlete. Some borderline changes are also there, which in an endurance athlete, we can expect some amount of left atrial enlargement, right atrial enlargement, and left axis deviation and right axis deviation. And we can even accept a complete right bundle branch block. What are totally abnormal is if there is a left bundle branch block, T inversions beyond what I have already told, pathological cues, epsilon waves of ARVD, Brugada type. So further higher degree AV blocks like type 2 MOBITs or grade 3 AV block, atrial arrhythmias and ventricular arrhythmias. So all these are red flag signs for us to evaluate the patient further. If it is any of these green ones, we can still wait if the patient is not symptomatic and there is no family history. So this is just the ECG. We can see that this ECG is showing sinus bradycardia, heart rate around 45. So that is normal for an athlete. Then you can see the T inversions are there. with an incomplete RBBP. So incomplete RBBP is also a normal feature. You can also see early repolarization changes in the lateral leads. So that is also a normal feature of an athlete. So this is an athlete's ECG, and some you can see the QRS is also quite high voltage. So like a left ventricular hypertrophy, which also we are okay with. So this is a classical athlete's ECG, so we are not worried about this. So, influencing factors, we already looked at age, gender, ethnicity, and type and intensity of sports. So, here we have the juvenile V1 to V3 teen versions are seen. Ethnic variant, which is seen in the blacks, where you can see from V1 to V4, and athlete's heart, which we have already seen, like the sinus bradycardia, some amount of atrioventricular block, early stages, vagotonic, bradycardia, early repolarization changes. So these are all aspects of a athlete's ECG. This is just a juvenile pattern, which we are again showing you. So when we see a patient with exercise-induced cardiac remodeling, as we see here, either a chamber enlargement or concentric hypertrophy, we will look at the echocardiography next. So when we look at the echocardiography, we are going to be looking at the thickness of the LV wall. Normally in an athlete, thickness will not be more than 15 mm. So if anything more than 15 mm, we need to consider abnormal and evaluate further. Less than 15 mm can be considered normal, depending on what is the pattern of hypertrophy and what are the symptoms of the patient. Accordingly, we can decide whether we need to go for further investigations or not. So I will show you some examples as we go further. So this is one of the athlete. This is an endurance athlete whom I have seen. So I have just put some picture. So endurance athlete who had symptoms, but echo didn't show any features of changes, but ECG did show some changes of the athlete's heart. So here we can clearly see this is a mitral valve pulse wave Doppler velocity, wherein E by A wave we can see, and there is no diastolic dysfunction. So generally in endurance athletes, we know that endurance athletes with more of dynamic component, we know that the diastolic function actually improves very well. That is very clearly shown by this pulse tissue Doppler imaging, wherein you can see the E prime is going up to 19. So if the E prime is so good, it means that the early relaxation is very good in the person, and there is no diastolic dysfunction at all. So when we look at though ECG was showing significant LVH and high voltage QRS, we can see that the IVS, this is the interventricular septum, thickness is around 1.1, that is 11 mm. So it is much less than the 15 mm mark, and probably this is all part of the athlete's heart. This is again about of the same athlete. So we can see that I have done a strain imaging. There is not much of abnormality in the strain imaging, though the global longitudinal strain is borderline. Less than 16 we would consider as abnormal. 17 and less we would consider as abnormal, but it is around 16. So we can know that the ejection in a dynamic endurance athlete, we know that some reduction in ejection fraction is expected. So this again goes with that, with the normal diastolic function. So these are few aspects that about the echocardiography. So when we look at evaluation of an athlete for decision making, first is we are looking at the athletic history. What type of sport? What is the intensity of sport? And duration. How much duration they are actually practicing every day. So, and competition history. Then we look at the gender, because men are more prone. Age we are going to look at, and the ethnicity. So after we have looked at all this, we are going to put them through certain types of tests. So first is an ECG, then we'll have an echocardiogram. So once we know there is some problem or no problem, based on that, we will choose the next set of tests. It may be a cardiopulmonary exercise testing to see the VO2 max and correlate with the LVH, or it may be just a stress test to rule out coronary artery problem, or cardiac MRI to look for any of the cardiomyopathies, or a CT coronary angiogram to see for any plaques in the coronaries. So, depending on what the symptoms are and how we want to go further, these are the few tests that we will be looking at. And once we look at them, we will come to a diagnosis of whether it is a physiological adaptation to the exercise that the heart is showing or a pathological one. So, based on that, we will give them some form of prescription on the risk stratification, athlete surveillance, as well as exercise of how much they can go through. So, this is the overall view of the basics of sports cardiology today. So, thank you. I'm ready to take any questions if there are.
Hello.
Yes, sir.
Madam, very interesting, madam. It was very nice. We didn't know the difference of, that endurance heart with respect to strength athlete heart. It is very interesting actually came to know. Just a few, I wanted to know, madam. You know there is a risk of cardiac arrest is increasing while doing exercise in the recently. What do you think? What is the cause for those aspects, madam?
That is what, sir. We need to stratify. Actually, the next talk in the series is prevention of sudden cardiac death during
Okay.
exercise. So
Okay.
maybe we can discuss in detail in that. But
Uh,
apart from that, we actually, before anybody goes for a high intensity training, they should
mm,
at least have a basic ECG, if
mm,
possible, an echo also. We look
mm,
at family history. If there is
mm,
family history of sudden cardiac death, they already come under high risk, even if the ECG and echo are going to be normal. Then
mm,
coronary artery disease has also come up in a big way. So we
mm,
need to stratify them for coronary artery disease because
mm,
most of them who have sudden cardiac death, one is either cardiomyopathy which is not detected, or
mm,
they may have coronary artery disease which is not detected, or they may have plaques which because of the increased stress
mm,
during the activity can have plaque rupture and MI during the
mm,
activity. So
mm,
these type of risk stratification when we can do, then
mm,
we are okay with any form of activity. That time, in fact, now sports cardiology, the pioneers are from UK, King
mm, mm,
George University. So what they actually recommend is they actually recommend CT coronary angio in symptomatic athletes if they have risk factors.
mm,
No point waiting on a treadmill test.
mm,
Actually, in one of these series, I wanted to show a case also of how treadmill test didn't pick up even a very tight stenosis. So that
mm,
because their VO2 max is much higher than our treadmill test. So the
mm,
treadmill test is never going to test a endurance athlete in their full form.
mm,
That way, unless we do a CT coronary angiogram or a regular coronary angiogram, we may not be able to pick up these type of plaques, and then they will end up with some form of acute coronary syndrome during the event.
Do you find any difference or anybody has find difference between pre-COVID and post-COVID era, the remodeling or any heart changes, madam, with respect to be?
Possible, sir, because most
Mm,
of the COVID patients actually had a lot of vascular inflammation.
mm, mm,
So we have not checked all of them for how much vascular inflammation
mm,
they have.
mm,
So that way, only a CT coronary angiogram or any other form of vascular markers are going
mm,
to like a high sensitive CRP. So those things will probably pick up the amount of vascular inflammation any person is going to be having. So that
mm,
way, post COVID, I'm sure there is increase in the
mm,
number of cardiac events because
correct.
of the inflammation in the vessels.
Mm,
Apart
mm.
from that, COVID actually encouraged a lot of people into exercise.
Exercise.
Yeah,
Mm,
so that way, post COVID, the number of people who are exercising and doing high intensity activity and endurance sports has remarkably increased because that time they didn't have anything else to do.
mm, mm.
So that way also it works. So
What do you
those are
suggest,
the
madam?
mm,
How to increase their activity with respect to like a not doing any exercise person, how you will start going for this endurance or strength
That is what, sir. If they are going just for a mild to moderate activity, it may not matter much.
Mm-hmm.
When they are going to moderate to high intensity,
Higher.
then they need to be evaluated clearly for risk factors. Of one is coronary artery, the other is cardiomyopathies. So QT prolongation. So all that need to be looked into. Once we stratify them as very low risk, they can go ahead with high intensity activity.
Okay, my question is from moderate to high, how much time they should take? Like 6 months, 1 year?
That is okay, sir. That if it
Uh-huh.
is graded, they
Nothing.
can go. So if
Mm-hmm.
by chance somebody has very clean coronaries
Mm-hmm.
and no cardiomyopathy and no risk as such, we are
Mm-hmm.
not worried about how fast they go into the
Mm-hmm.
high intensity activity.
Okay.
Uh, Only thing, it should be scientific and graded, not
Okay.
suddenly going into high intensity activity that the heart will not be able to take. There are many people who suddenly go for Char Dham Yatra and
Mm-hmm.
commence the high intensity
Mm-hmm.
without any effect. They actually come back with stress cardiomyopathy, dilated LV, LV dysfunction, which recover over a period of time, but they take a long time to recover. But first, they have to survive the insult and
Okay.
come back. After that, they can recover.
Like you told ECG changes, madam, in the that green table. It was
Mm.
nice actually. It's like that. Is there any changes with respect to cardiac enzymes, NT-proBNP, CPKMB, TROPI changes will be there?
Uh, they will have proper elevations after
Uh,
high intensity activity. They will
mm-hmm.
have proper elevation, but serial proper elevation may not be there.
Mm-hmm.
Soon after activity, like even supraventricular tachycardia or anything for that matter, which
Mm-hmm.
increases the load on the heart, can
Mm-hmm.
cause some amount of myocardial injury, which will increase the troponin I or the cardiac enzymes.
Mm-hmm.
So that way, when we do a serial evaluation, like a myocardial infarction, it won't go up.
Mm-hmm.
It, it will be just maximum at one level or remain static, or it will start coming down.
Coming down.
So that way we can evaluate, and proper elevation post exercise, high intensity is very well.
Thank you, madam. It was very interesting actually. So I think many people should see this series. Uh, your volume is very low, madam, with specs, so I have to wear my ear.
Okay, okay,
Oh,
sir. So next time I'll try to
yes, madam. Yes,
give
madam.
some.
Okay. Oh, okay, madam. Thank you, madam.
Thank you so much, sir.
Thank
Thank
you.
you for the opportunity.
Ma'am, that was a captivating presentation, ma'am.
Thank you.
On behalf of everyone here, I want to extend a sincere gratitude to you, ma'am, for sharing your profound expertise on the topic. Your insights not only comprehensive, but also undoubtedly equipped with all the scenarios, deeper understanding of this critical field. Thank you, ma'am, for the enriching presentation and the
Thank you
good
so much.
enriching discussion with Dr. Raghunath, sir. Thank you,
Thank
ma'am.
you so much. Thank you, everyone.